Hello, my name is Satish R. I'm a professor of cardiac sciences at the University of Calgary. I was asked to give a talk about the issues around dysautonomia and Ehlers-Danlos syndrome. I want to thank you all for having me. I apologize for not being able to be live with this presentation. When we talk about dysautonomia, one of the problems is it's not a thing. It's actually a huge universe of things. It's a little like saying someone has heart disease. It absolutely can be true, but it's not necessarily helpful as a diagnosis. So for the purpose of this talk, a lot of it will be focused on issues around postural orthostatic tachycardia syndrome, or POTS, and Ehlers-Danlos syndrome, recognizing that there is a spectrum that we'll touch on, and some of the treatments and approaches that we talk about and that we use for managing patients with POTS and Ehlers-Danlos syndrome would apply to those that don't quite meet POTS criteria as well. My conflict declarations are here. I do a little bit of consulting for companies interested in neurogenic orthostatic hypotension and POTS. I serve as an associate editor for Autonomic Neurosciences, and I have research grants that are peer-reviewed, and those monies don't come directly to me. So what is POTS? The definition has been tweaked, but fundamentally hasn't changed in about 30 years when it was defined by Philip Lowe at Mayo and his fellow at the time, Ronald Schondorf, who's actually an eminent neurologist at McGill currently. The criteria involve both physiology and symptomatology. So the physiology criteria, the hallmark, if you will, is that the patients have an excessive orthostatic tachycardia, and based on some tilting that they had done in healthy volunteers at the time, they defined that cut point, the line in the sand, if you will, as an increase of greater than 30 beats per minute. Now, they only studied adults, and one of the things that became clear is that orthostatic tachycardia physiologically decreases as we get older, or conversely, it can be very high and normal in the young. And so after doing some work in school kids, where they realized the number that had excessive orthostatic tachycardia using that 30-beat cutoff, but were otherwise perfectly healthy, that number was redefined to require an increase of at least 40 beats per minute in patients from 12 to 19. We actually don't have North American criteria for those patients under the age of 12. This tachycardia has to occur at least some of the time in the absence of orthostatic hypotension. If the tachycardia only occurs in response to the hypotension, then that's a reflex tachycardia, and the ultimate diagnosis is orthostatic hypotension. So it's not an issue of the patients don't have anything, they have something, but they have something, orthostatic hypotension, that's actually been recognized for a much longer time. So taken together, that's POT, that's postural orthostatic tachycardia, that's physiology. The key to POTS is the S. So these patients are symptomatic, and the symptoms should be worse, at least some of them, if not necessarily all, but a lot of the symptoms, the dominant symptoms, should be worse when the patients are upright, and better when the patients lie down again. The cause of the symptoms can vary. Some are probably due to changes in cerebral blood flow, some due to excessive sympathetic activation. But the hallmark is worse upright, better lying down. And these have to be chronic. We used to use a minimum of 6 months. We've redefined that probably to 3 months. The truth is it probably doesn't make that much difference. But what you want to avoid are diagnosing people acutely. And the reason is because when any of us get sick, if we get a bad cold or a flu, and we actually want to try and assess ourselves in terms of the physiology of orthostatic tachycardia or the symptoms, many of us might meet the criteria for POTS for those few days when we're really unwell. The difference is we usually get better. We get better within a few days. The point here is these patients don't. This is a chronic problem that lingers well beyond that acute phase. And then the final criterion that's sometimes listed and sometimes not, but always implied, is that this is in the absence of another obvious cause for tachycardia. So for example, if you have Addison's disease and you're not able to retain salt and your blood volume is low, and that's because of a specific pathophysiology we recognize, then we should diagnose you with Addison's disease and treat that, as opposed to giving you a diagnosis of POTS. The implication of POTS is that there's not a clearly understood pathophysiology accounting for this tachycardia. Now, as the definition in some ways is straightforward, there are clear criteria. It's a positive diagnosis, not one merely of exclusion. But it can be difficult to apply, and the challenge is that there are nuanced layers, the onion peel, if you will. And so when we put together the Canadian Cardiovascular Position Statement a few years back, we actually tried to plot the ecosystem, if you will, of orthostatic intolerance on a Cartesian plane. And so POTS, seen up here in the top right, requires both a lot of symptoms and a lot of orthostatic tachycardia. But there are patients that have symptoms very similar to POTS. Some would argue the symptom profile can be identical, but in the absence of orthostatic tachycardia. And so until this statement, this group didn't have a label. And so we'd have issues where some patients were being misdiagnosed with POTS, which has implications in how we treat them, and others just saying, no, you don't have POTS. And while the intent may not have been to say there's nothing wrong with you, that was sort of what would sometimes be interpreted. So I'm not sure this is the best name, but we came up with the term postural symptoms without tachycardia, or PSWT. But something to recognize that there's clearly something going on, but it's not a tachycardia-based thing like we see in POTS. Of course, you can also have tachycardia of other causes. We alluded to Addison's disease in the prior page, so that's not POTS either. And then you have the healthy group that doesn't have too much orthostatic tachycardia and doesn't have too much in the way of symptoms. One of the things we realize that if we're trying to track these patients and use metrics to say, okay, have we made them better or not, the better depends on what problems they came in with. So certainly for patients that primarily have these orthostatic symptoms, that's probably the, if you want to call it, the pure POTS group or the pure PSWT group. And we'll get into this in a moment, but then there are a bunch of patients, probably the majority of patients, that actually have other things going on, in many cases that are dominant symptoms as important as the orthostatic intolerance, in some cases more so. And so if we fix the orthostatic intolerance, we fix the orthostatic tachycardia, we're still not going to necessarily make huge improvements in their quality of life unless these other things are addressed in whatever way they can be addressed. And we touch on those here. So in terms of the plus part, the POTS plus or the PSWT plus, really we weren't trying to be prescriptive, but put different disorders that are seen in here to give people an idea of the types of things that could have a dominant negative effect on quality of life. So problems with gastric emptying, intractable vomiting, severe bladder issues, severe pain, severe allergic type reactions, right? Again, treating the hemodynamics can make a part of that symptom constellation better, but if these other dominant symptoms aren't affected or addressed, that can still have negative effects. And these can cluster in patients with specific associated comorbidities, and you'll see that hypermobile spectrum and hypermobile EDS are high on the list, but there are other things on the list as well that can have a dominant negative effect on quality of life. And that's why we came up with that classification. If you're interested in this, the citation is here, and this is freely available as an open access publication. So the common symptoms in POTS are broken down here from a cardiologist viewpoint. So I broke them down into symptoms that I can blame on the heart, and other symptoms that I have a lot of trouble directly blaming on the heart itself. The symptoms in black on top in both groups are those symptoms that are worse with upright posture. So in terms of the cardiac symptoms, a rapid heartbeat or palpitation, chest discomfort can get worse, can be associated with shortness of breath, lightheadedness. All of this fits with a tachycardia-related issue. But a lot of patients, the vast majority, complain of mental clouding or brain fog. The vast majority have headaches. Most patients have some form of nausea. A lot of patients complain of tremulousness. And again, these are things that do get worse upright, sometimes, often. But these aren't things that I can directly blame on the heart. At the bottom are symptoms that aren't positional. So patients routinely, the majority, have exercise intolerance, sometimes profound. Almost everyone is fatigued. Sleep complaints, again, the vast majority. Obviously, we don't ask patients to sleep upright. They have trouble sleeping even in the supine position. So this slide just is trying to convey the physiologic hallmark, right? So this shows a tilt table test in a POTS patient on the left and a healthy control subject on the right. This was done several years ago. We have the heart rate channel on top, the continuous blood pressure channel in the middle, and the tilt angle on the bottom, just so you can see where the table went up and then the table went down again. And if you look at this, there are a couple of things to get from this. The first, if you focus on the control subject on the right, is that orthostatic tachycardia, the heart rate going up with upright posture, or in this case tilt, is normal, right? That's physiologic. We see it in the control subject. If you focus on the blood pressure and compare the two, I think it's hard to argue that the average blood pressure in the POTS patient is lower than in the control subject. It's either the same or even perhaps marginally higher. I think if you were to look at the tracing, you could look at it and say it looks different. It looks spikier. It looks sort of like I do when I'm in desperate need of a haircut and I can't get my hair to settle down, right? It's all over the place compared to the control subject, but the average pressure is not different. And these spikes actually may be important. It may be part of the message we're getting in terms of autonomic regulation and its attempts to maintain blood pressure. And finally, if you come back and look at the heart rate in the POTS patient, the heart rate went up like in the control subject, but a lot more, right? So orthostatic tachycardia normal, but in this POTS patient, they were really an overachiever. This patient didn't make it through the protocol, which was a 30-minute tilt. This patient had to stop early because she felt so unwell. And when she had her at a stop, her heart rate was 180 beats a minute. And the only thing we had done was to tilt her up. But as I said, POTS requires physiology, but physiology is not sufficient. It's a disorder that's characterized by symptoms, often disabling symptoms. And so during these tilts, we actually had patients rate their symptoms, and we see data for the POTS patients in red and the control subjects, the healthy controls, which were grad students at the time, in black. And if you look at the control subject data, for the most part, the patients were asymptomatic. Every once in a while, they get a little symptomatic, and then they'd faint, and they'd be sent, the data would be censored, and they'd be asymptomatic again. In contrast, the POTS patients were symptomatic very early on. And they continued to be very symptomatic, get more symptomatic throughout the tilt. The interesting thing was, even though the POTS patients kept telling me they were going to faint with the burden of symptoms and how unwell they felt, more of the POTS patients made it through the 30-minute tilt than did our healthy control subjects, right? And that illustrates the point that POTS isn't primarily a fainting disorder. POTS is primarily a feeling faint disorder, a feeling like I will faint disorder. A minority of patients with POTS do also trigger a fainting reaction, typically vasovagal syncope, but it's not high in the differential if fainting is the primary problem as opposed to feeling lightheaded. So who gets POTS? What does it look like? Until a few years ago, basically what we had were data from some small studies, single center often, and quite frankly, we published a lot of that when I was at Vanderbilt. But in conjunction with Dysautonomia International, a POTS patient advocacy group largely based out of the US, we put together a large patient community survey. Right? So this is ethics approved through Vanderbilt, largely distributed through social media. And this is the first paper that came out a few years ago. At the time, I think we had between 4,000 and 5,000 people had responded. We now have closer to 10,000. But it gave us some insights broadly as to what the community looked like. And what we saw is actually similar to what we'd seen at the single-site studies. Overwhelmingly female. In this cohort, I think it was around 93 or 94% of the respondents were female. Overwhelmingly white. The one caveat is that this survey was in English, and it was, there were responses from many parts of the world, but overwhelmingly, the number one responders were in the United States. So that may affect the racial profile that we see in the survey. But again, this fits with what we'd seen in studies out of Mayo, out of Vanderbilt, out of Boston, that the demographics are very similar. When we look at the age distribution of the onset of symptoms, the most common age, the mode, was 14 years old. But it's not just at 14 it goes away. There's a long tail to where just over half the patients reported onset of symptoms under the age of 18 and just under half over the age of 18. Right? And this probably speaks to the fact that POTS isn't likely one thing, but there may be different things going on representing this changing demographic. we had a laundry list of symptoms that patients could endorse. And the top ones reported by the patients are listed here. If you look at the first few, lightheadedness, tachycardia, presyncope, these are things that you would expect in a disorder with tachycardia in the name. But if you look just down below that, headache, difficulty concentrating, nausea, memory problems, these were seen in 90 plus or more percent of the patients, right? So again, there are symptoms that are typically cardiac or tachycardia related, but there are a lot of symptoms that aren't, just pointing to the fact that there is actually a multi-system issue at play, and it's not all about the tachycardia or all about the heart. From the survey, we looked at lists of comorbidities. These are all patient-reported. So obviously the patient would have had to have been told or been diagnosed with this. So there's limitations. We didn't have people actually going through and making sure that everyone was assessed for all of the things. But it's still revealing. You may be interested to see that Ehlers-Danlos Syndrome was reported in about 25% of this group, which fits in the plus or minus 5% range with what's reported in smaller studies. Vasovagal syncope actually only reported in just under 15% in this group. Some have inappropriate sinus tachycardia, and then there's sort of a hodgepodge of autoimmune diseases, none of which are actually that predominant in and of itself as an individual disease, but if you add them all up, it amounted to just over 15% of the group. A lot of the patients had onset when they were teenagers, and so education becomes a potentially important issue. And looking at the data we saw, it's actually quite problematic. As a result of the POTS, so because of the illness, almost 90% of patients reported having missed some school. Almost 30% were homeschooled at some point. 25% have had to drop out of school. And almost 40% either delayed enrollment in university or had to actually stop before sort of postponed starting, delayed when they're, or actually had to stop university. So huge impacts on education. And the critical issue with education is this isn't actually just about these 2 years, 3 years, 4 years are difficult. But if these children and young adults are missing that much school and education, it's likely that their overall path of education has changed. And that has implications not only for the next few years, but that has implications for the next several decades in terms of their life trajectory, in terms of work, in terms of ultimately income. So what about quality of life in POTS? And some of this work that I'm going to show was led by a colleague at Vanderbilt, a sleep neurologist named Kanika Bagai. And as part of a sleep questionnaire study we're doing, we looked at quality of life. These data are not POTS data, but one of the things we looked at was the SF-36. For those not familiar with it, it's a 36-question survey of health-related quality of life, and it's generic, right? So it's nothing about it is POTS specific. It's not going to be that sensitive, but the beauty of it is that because it's so ubiquitous, pretty much there's data on every disorder out there. People have looked at this in just about everything. And they typically the scores can be broken down into sort of a physical health and a mental health subset. We see data here for 2 disorders that are thought to have a poor quality of life: patients with chronic back pain in green and patients with end-stage renal disease on hemodialysis in purple. And I superimpose here data we'd collected in our POTS cohort. Right, so this doesn't speak to why, it doesn't speak to whether the judgments are reasonable. These are all self-reported in all the groups, right? And the point is, regardless of what's going on, it has a huge negative impact on quality of life, both on physical health and on mental health. So is POTS a psychiatric disorder, right? Really, the question we're asking is, are POTS patients crazy? And I ask that not because I'm suggesting they are, but this is certainly something that I've heard and I think patients have heard from other people. So this was formally assessed at Vanderbilt. The pointy end of the spear in this research was my wife when she was a research fellow before doing her psychiatry training. And ultimately, the answer at the time was they're no more crazy than the general population, right? So they administered structured battery at the time, mapping to diagnosis in the DSM-4-TR, which was, at the time was sort of the diagnostic Bible in psychiatry. There are more recent iterations of that, but I suspect the answer hasn't changed. So yes, patients with POTS had major depression, some did. Yes, patients with POTS, some had an anxiety disorder, but it turns out that exists in the general US population as well. And the incidence was not higher, the prevalence, sorry, was not higher in the POTS group. But they looked at different traits, they looked at anxiety scores, they looked at depression scores, and the only thing that really popped up as interesting and abnormal in the POTS patient was inattention. So this was actually an ADHD score checklist. And what you see here is that compared to normals, psychiatrically normal population, the POTS patients had more inattention. Well, it turns out these patients are uber normal, right? So they actually had to be screened to be normal. And so it may not be a proper reflection of what you're actually wanting to compare to. But if you looked at published literature based on US populations of so-called healthy people, not screened to be normal, but just the average population, the POTS patients actually had more inattention than general. Not as much as ADHD here in blue, but more than the general population. And the whole issue here was that this sort of twigged us into something that probably needs to be followed up more now than before. But patients would often say, I have memory problems, I don't remember things. But this got us thinking that part of the problem might not be the memory per se, but it might be an inability to process the memory due to attention. We followed up that study with a more detailed neurocognitive study at Vanderbilt. This was led by Amy Arnold, who was a postdoctoral fellow at the time at Vanderbilt, who's now an associate professor at Penn State. And we did a study with a little bit of standing, but we actually looked at patients sort of seated in bed in a sitting position, I think with their legs up, to basically try and figure out if there are even baseline abnormalities. And what we found is that the POTS patients did worse on tests of executive function, and they did worse in some tests of attention like before and cognitive processing. So there were structural abnormalities that correlate to some extent with these subjective symptoms of brain fog. So why? Like, why do these patients get this thing that we call POTS? And it's a complicated question without a clear answer, and there are challenges. But one insight came from David Robertson, who's my mentor at Vanderbilt, who argued that one should think about POTS not as an end diagnosis, but a final common pathway. So a diagnosis of POTS is a little like a diagnosis of a fever. Objectively, there are criteria, it can be true. There are treatments. If anyone's had a young child with a fever, it's amazing what Tylenol can do to try and lower the fever and ultimately restore, the child to being running around. I remember when my daughter was a baby and had a fever, she was lying like a rag doll, which was scary to see because usually as a child she was always moving. Gave her Tylenol, she was still febrile, less febrile, and all of a sudden she was running around again, right? So there are treatments that work. But ultimately there are a gazillion causes of fever. Different viruses, bacterial infections, cancers. There are a whole bunch of things that can cause a fever, and so it's an end result and not necessarily the final answer. When studying POTS, the challenge is akin to the old tale of the blind men and the elephant. And it goes like this. This is the Hindu version. Every group in the Indian subcontinent has a version of this fable. Like a lot of things in India, a Brit, Jeffrey Sachs, came and took it and published and got credit for it. But it goes like this. It was 6 men of Hindustan, to learning much inclined, who went to see the elephant, though all of them were blind, that each by observation might satisfy his mind. They conclude that the elephant is like a wall, a snake, a spear, a tree, a fan or rope, depending on where they touch. So the challenge in POTS research is that everyone coming into the research comes into it with their specific strengths, their abilities, their interests, and they assess patients based on that. And so people then describe what the problems are from that perspective, and sometimes it's hard to pull these different perspectives in to sort of understand the whole. So coming back to the parable, I'm the one in the back, the blind man in the back, if you will. So in terms of pathophysiologies, there are lots of different mechanisms that are talked about. We're not going to get into any of these in too much detail here because of time. But some of interest are issues around mast cell activation. And I'd actually broaden, the term is mast cell activation or mast cell activation syndrome, but more broadly, there's a strong allergic component in some people that I think probably plays an important role. Partial autonomic neuropathies have been shown in some people. Leg blood flow abnormalities that may link to the autonomic neuropathy have been shown in some people. A lot of patients have low blood volume, and so there may be a blood volume regulation problem. Ultimately, you can have a hyperadrenergic state. That's been shown in different groups of people. And there's been a lot of interest in autoantibodies and autoimmunity, and certainly with COVID in terms of the inflammatory response. Although the details of exactly the role each of these plays is still a bit unclear. So just a word about the mast cell approach. If you want to test for it, this is the approach that we've often used. So patients can present the classic report from Cynthia Chabot and Italo Biagioni, who were colleagues at Vanderbilt, were patients that would describe episodes where they flush and turn beet red and then get really tachycardic. And so what we try and do is try and capture a urine collection after one of these spells to really optimize the chance of picking up mediators that were released by the mast cells to see if they're elevated, as opposed to doing a 24-hour urine randomly where, who knows if you have the spell or not, and even if you had the spell for a few hours in a 24-hour day, that may get diluted out in the urine. So instead of a 24-hour, you would actually collect a 4-hour urine sample right after a spell. So spell would start, we get people to empty their bladder and then collect urine for 4 hours, and ultimately send it off for methylhistamine, histamine metabolite, and sometimes prostaglandins. They're more available in the States, the other metabolites. And if these patients actually seem to have this, the treatment involved multimodality histamine, antihistamine blockade or histamine blockade, sometimes high-dose nonsteroidals, in particular aspirin is recommended. And that worked at the histamine level, the prostaglandin level, the stuff being released. But Dr. Biagioni actually came up with this concept that this led to activation of the sympathetic nervous system and increased sympathetic nervous system outflow that then fed forward and made it easier for the mast cells to release more histamine and prostaglandins. And so he pioneered the use of methyl-dopa to try and help break that cycle. So it's a central sympatholytic drug. Okay, so what about Ehlers-Danlos syndrome? So this is obviously of particular interest to this audience. And there are some data. So this work out of Belgium compared autonomic symptoms, broadly defined, in a cohort of patients with the hypermobile form of Ehlers-Danlos syndrome. So this is before the 2017 definitions. And what we found compared to controls, and what we found was that in orthostatic intolerance in particular, there was a lot more seen in this hypermobile group. The truth is that pretty much for all of the autonomic symptoms, the rates were a little higher, but at a low level than the control participants, but really high for orthostatic intolerance. And if you actually then look at subtype comparisons within Ehlers-Danlos syndrome, comparing the hypermobile type to the classical type of EDS, what we see is that the classical type does have more symptoms than we saw in the control group, but the hypermobile type seemed to have a higher amplitude. So the symptom burden across the board was a little bit higher in the hypermobile group than in the classical group. So as part of that big POTS survey that I alluded to earlier, we tried to look at this more specifically. So obviously it was a patient self-reported survey. We did ask patients to confirm they had a physician diagnosis of POTS and it wasn't just made on a guess. So the data that I'm presenting here was from a cut from April 2021. And what we found is of the close to 7,500 people on the survey, about 25% reported having a diagnosis of Ehlers-Danlos syndrome in addition to their diagnosis of POTS. One of the interesting things that came out, more so than anything else in terms of predominance, was the association between the diagnosis of mast cell activation syndrome and Ehlers-Danlos syndrome in this cohort. So patients that had both POTS and EDS were 5 times as likely to tell us that they'd been diagnosed with a mast cell activation syndrome or disorder than patients with POTS without EDS. When looking at more traditional characteristics, the patients with POTS and EDS were diagnosed at a slightly, actually not diagnosed, sorry, the symptom onset was at a slightly younger age. So again, the peak was during those teenage years, but everything was shifted a little bit younger in the POTS EDS group. There was a slightly higher family history of both fainting disorders as well as POTS in the POTS EDS group compared to the POTS no EDS group. There was a slightly higher rate of misdiagnosis, although I will say that the rate's pretty high in both groups. I don't think it's fair to say that this is unique to the POTS EDS group, but you know, quantitatively it was slightly higher across the board in the POTS with EDS group. And in terms of diagnostic delay, it was longer again in the POTS and EDS group than in the POTS no EDS group. But again, really long in both groups, right? So it's not that one group has it, you know, really well and the other doesn't. They both groups actually have unacceptably long delays. Looking at the classical POTS symptoms, so these are largely the cardiovascular hemodynamic symptoms, very similar, right? I mean, one of the beauty of doing statistics with 7,500 samples is that even small differences can be statistically significant, but it's hard to look at this and argue they're vastly different. In terms of neurologic symptoms, so these were symptoms related to tingling or numbness or change in color of the limbs, again, consistently a little bit higher in the POTS patients with EDS than those without EDS. And similarly with GI symptoms. So overall from this, you know, the key take-homes are about 25% of our POTS cohort were co-diagnosed with Ehlers-Danlos syndrome. These patients had a slightly younger age of onset, more likely to have a family history of fainting or a family history of POTS, more likely to be diagnosed with mast cell activation syndrome, and both a longer diagnostic delay and more diagnostic challenges. Right, so we'll see, but the hope is that this may lead to some further work giving us more detail or revealing clues as to the why. But ultimately, if people want to know what the mechanism of orthostatic intolerance is in EDS, we don't know. Right? I think I am always fascinated that a lot of people are quite adamant that EDS is causing their POTS, but the reality is both end in the word syndrome, right? There are clinical characteristics that define both. And what's lacking right now is really an understanding of how one gets from here to there. And that's an area that we definitely need more research in. So I get a lot of patients who come to me wondering what subtype of POTS they have. They've heard of H-POTS or hyperadrenergic POTS or N-POTS or neuropathic POTS, and they want to know what they have. And that brings up the broader question of, is that valuable? And the short answer is no. And the reason is shown here. So we sort of think about different subtypes of POTS as discrete entities. You have hyperadrenergic POTS, you have neuropathic POTS, you have hypovolemic POTS, and that's it, right? And these are actually 3 different disorders. But the truth is that the world looks more like this. So there are people with exclusively remarkable hyperadrenergic features. There are people that have hypovolemia and not the other things. There are people with neuropathy, but most people actually fall into overlap groups. Most people with hypovolemia often have a hyperadrenergic presentation. The hypovolemia to some extent may relate to neuropathy and flow-related issues, right? So they're not discrete. In fact, there are studies done where they look at specific test characteristics to define hyperadrenergic or neuropathic in a specific study. And that's fine. They're actually being very honest about what they were looking for, but it wasn't about the label. And there are some patients that have been in the same studies for neuropathic POTS, but also in studies for hyperadrenergic POTS, for example, at Vanderbilt or at Mayo, right? So you have to be careful taking abnormal test results, which may tell you something about how to treat or what's going on, and broadening that to subtypes or terms that are poorly defined and often defined differently by people. Okay, so I'm going to finish with what do you do, right? How do we actually care for these patients? So I'm not going to belabor the point about investigations. The truth is that there's a very small set of investigations that are deemed to be mandatory for everyone, right? History and physical exam is critical. Orthostatic vital signs critical. You can't actually diagnose an orthostatic tachycardia or an orthostatic hypotension related disorder without measuring orthostatic vital signs. The Canadian Cardiovascular Society position statement, and I believe the Heart Rhythm Society position statement from a few years before, recommends some basic testing, a complete blood count, an electrolyte or metabolic panel, a thyroid stimulating hormone level to rule out hyperthyroidism, to avoid potentially obvious reversible causes of this. There are lots of other tests that you may want to do in individuals. So the list below is really not exhaustive. It's, we often do autonomic reflex testing, but we're a tertiary care center that may, again, give some information on characteristics and how someone may respond to treatments in a more nuanced way. You want to make sure the heart is structurally normal, and this can often be done by physical examination, but if it can't, then an echocardiogram just to make sure the heart is okay is worth doing. Blood volume assessments can be useful. In Canada, practically very difficult to get. At a clinical level, we can do a research version. And if you're following patients serially over time, assessments of exercise capacity may be useful to get an objective sense of where people are. There are lots of other tests if there's elements of the history strongly suggesting very dry eyes and dry mouth. It may be worth doing a workup for Sjogren's syndrome, for example. So it's not that more stuff shouldn't be done, but everything else should be guided by that history and initial examination. In terms of treatment, everyone gets a foundation of non-pharmacological treatment, and some or many also will get pharmacological treatment on top of that. The non-pharmacological approaches that I use involve dietary salt expansion, compression garments, and exercise, and we'll talk a little bit about each. So historically, we recommended take more salt. I think most patients have probably heard that from doctors, but until recently, there was actually very little data to support that. So we published a paper a couple of years ago. This is work done at Vanderbilt several years ago when I was still there, where we brought in patients into our research unit for 2 one-week stays. And these were several months apart. These were all young women, so we tried to bring them in at the same phase of their menstrual cycle. And during one of the weeks, we had them on a very low sodium diet, and in the other week, a very high sodium diet. And we basically gave them a week to reach a steady state with the diet and then did extensive evaluations in the last couple of days. And what we found is actually that salt did what we thought it would do, and that is that by increasing the dietary salt intake, the patients retained fluid and expanded their plasma volume, expanded the liquid part of blood. In turn, that decreased the standing plasma norepinephrine level on when they were upright, and that decreased the upright tachycardia. Right, so the lower volume, the volume contraction was driving some of the increased sympathetic tone and driving the heart rate. So that told us that it was the right thing to do in terms of the physiology, at least acutely, but how? And so this is the approach that practically I use in clinic. I encourage all my patients to get in at least 3 liters of water per day. It's often practically easiest if they have a dedicated water bottle that they use. And the different guidelines sort of say 8 to 10 or 10 to 12 grams, but roughly an extra 10 grams of salt per day is recommended. Now, I could not add up and count how much salt I was getting in, and I can't instruct my patients to do so. And so the approach we've come up with is what I call the teaspoon approach or the Ziploc bag method. We have patients take 2 teaspoons of salt. Each teaspoon of salt is about 5 grams, so 2 teaspoons is 10 grams. and to put it in a zip snack bag in the morning. And their job is to get that in them through the day. Most patients find it easiest to add to food. They don't mind the taste of salt. Some like the taste of salt. That's the easiest way to get it in. There's some that don't. And they end up finding other ways. And that could be adding it to water and drinking it, adding it to hot water and lemon juice, or some of the younger patients will actually do saltwater shots where they add 1/3 of a teaspoon to water in a shot glass and do the shots. If you're doing that, don't do it on an empty stomach. But it doesn't matter how it gets in. It doesn't have to get in with the water, but it has to get in. I don't tend to use salt tablets very often. The only time I think it's really necessary is if patients really hate the taste of salt, in which case regular tablets will be okay, although I think it tends to cause more gut grief and more nausea. Or if they really get a lot of nausea with the table salt and their stomach doesn't tolerate it, there are gel-coated salt tablets. One brand is called Vitasium, which is available on Amazon. That does tend to be better tolerated, but if you're getting in salt primarily through those tablets and trying to get to the volumes of salt we're talking about, it can get quite expensive. How about compression garments? So the whole idea here is that when we stand up, fluid shifts from our chest, where our heart is, to below our chest, and that's blood that's not coming back to the heart that the heart can't pump. So Kate Bourne, a PhD student in my lab, did a very elegant study looking at compression garments, lower body compression garments, and showed that at least for a 10-minute tilt, the patients did repeated 10-minute tilts, that the use of compression garments obviously didn't prevent the heart rate from going up. It clearly did go up, but without the garments, the heart rate kept going up and shifting up, 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 and the compression garments significantly muted that. It made a difference. We actually looked not only at full compression and no compression, but sort of a bicycle shorts or abdominal compression model versus calf only or leg compression. And what Kate found was that the symptom score improved, lowered, the more compression you had, almost in a dose-dependent like manner. Abdominal compression was much closer to full compression than leg compression was. So if you're only going to compress one of the areas, the abdomen, pelvis, or the bicycle short compression much more important than the knee-high socks. And we were excited to see that the improvement or the symptom burden actually correlated with the improvement in the heart rate. Right? So the more we reduce the heart rate, the lower the symptom burden. How about exercise, right? So this is always one of the more difficult things. Exercise training is hard for everyone. Forget POTS, forget EDS, just in general. But there are clear data that exercise training helps, right? The seminal study from Chi Fu and Ben Levine in Dallas from almost 15 years ago now showed that a fairly short-term program, so a 3 to 6 month program, increased fitness levels, increased blood volumes, increased cardiac mass or cardiac remodeling, decreased sympathetic nerve activity, all stuff that I'm interested in as a physiology person, but patients don't care about, right? But it decreased the orthostatic tachycardia, and that is something that patients do measure. But most importantly, it improved quality of life. They also used the SF-36 that I mentioned earlier, and everyone that completed this protocol, which in fairness is not the same as everyone that started it, but everyone that completed their 3 to 6 month protocol reported an improvement in their quality of life. Some a lot, some a little. So how do you do it? So if you have an exercise physiology background, you can actually get the calendars they used in the study. They're published on the web. I don't have that background. I don't understand them, right? So I actually have tried to take underlying principles that they use, and I try and share that with my patients, and then the patients have to find out what works for them. So the key is that this is primarily about aerobic reconditioning, right? So there are other things like core strengthening, Pilates, that are really good for you, but they're not going to help here, right? So if you want to do that, that's an and not an or. That's not a replacement for this. In the study, they did do some resistance training focused on the thighs, right? And that's particularly an issue because some patients have very little muscle bulk, and you need some muscle bulk to store the fluid, but primarily aerobic reconditioning. The training had to be regular, so at least 4 times a week is what they were insisting on. I often ask patients to try for 5 or 6 times per week because even with the best of intents, life will get in the way and you're going to miss days. The sessions, fairly quickly, we try and get patients to do 30-minute sessions. Over time, that can increase in length, but fairly quickly to 30 minutes. In terms of the how, the most clever thing that they came up with was that they forbid upright exercise. And the interesting thing is, if you ask people, you tell people to exercise, and you ask what would that look like, almost always it's things like walking, running, treadmills, those evil elliptical things where you're vertical, things where you're standing, things where these patients with POTS are getting really symptomatic before they actually start doing the exercise. And so it limits what you can do. So the whole idea of non-upright exercise isn't that upright exercise is bad, but the hope is that it's going to be better tolerated. And in the study, they actually preferred the use of rowing machines, but if that wasn't possible, and in the Ehlers-Danlos patient group, sometimes there are issues with joint stability where the rowing machines don't work. Recumbent cycles are also an option. Swimming is an option. Right, so sometimes, especially if there are joint issues limiting one modality, it's a matter of finding out what can be done. And often the patients themselves are best at doing this because they can figure out what works for them. But something needs to be done, right? If you just say, I can't do it, you can't do it, but you can't get these benefits. Importantly, everyone in the study, I said, got better, but it doesn't happen right away. In fact, it can take 4 or 5 or even 6 weeks before you start seeing any benefits from this exercise. And in the interim, there's a good chance the patients will feel worse, right? You know, there's a very dark, long tunnel. There's light at the end of it, but it's dark and long, right? But once you get to the point where the flip switches and you start to feel a bit better, then you actually feel worse when you miss days of exercise, and so compliance becomes easier. But initially, it's very difficult. In terms of pharmacological approaches, there are a bunch that are listed here. The ones in blue are things that could help. Intravenous saline acutely can help. DDAVP, mitidrine, propranolol, a beta blocker, ivabradine, a fungal channel blocker, pyridostigmine or mestinon, acetylcholinesterase inhibitor. And I put in NET inhibitors or SNRIs in red here because these are drugs that actually can make the tachycardia and symptoms worse in these patients. So saline is very effective at reducing orthostatic tachycardia acutely, right? So this is a study published by Jairus Jacob at Vanderbilt in the late 90s. And if you look at the right of each of these panels for placebo, you can see that the heart rate didn't go down much with placebo, but with saline, it basically decreased by more than half, and the heart rate was well in the normal range with tilt post-saline than before. Okay, so saline helps acutely. The problem realistically with regular saline or long-term saline is not usually the saline, it's usually access, right? So if you keep giving saline through an intravenous peripheral intravenous catheter, you'll have trouble getting venous access, and then ultimately, if you then move on to PICC line and then ports, the concern is port complications, central line complications over time in this group. In terms of hemodynamic agents, so not the blood volume expansion agents, and there are other options listed here, but saline is sort of the classic one. Mitidrine is a short-acting pressor drug. It squishes blood vessels. And in the same study by Jairus Jacob many years ago, you can see that mitidrine did work. It helped lower the heart rate more than placebo, not nearly as much as the saline. We did a lot of work with propranolol. We had an inpatient study model where we did 4-hour assessments, and we were interested in other drugs, but propranolol at low doses was often one of the drugs we looked at, and inevitably it was the winner, even in patients that came to us saying, I don't tolerate beta blockers or they don't work for me. And we found that propranolol consistently lowered the standing heart rate more, lowered the orthostatic tachycardia more, and improved symptoms. But the question was, why did patients keep saying that it didn't work or it made them worse? And so it was actually Bonnie Black, our research nurse, that said, we tend to use low doses of drugs because patients are sensitive to drugs. So then we included a higher dose of beta blockade, a more complete beta blockade with propranolol 80 milligrams. And what we found is the symptoms started to get worse. So the key with beta blockers is just a little bit. Use a little bit to take the edge off the heart rate. not so much as to totally normalize the heart rate. And so we typically would use doses of 10 to 20 milligrams 4 times a day. Ivabradine is a newer agent. It's on the market in Canada and the US. It's not generic, and it's approved for a subtype of heart failure, so insurance coverage can be difficult. But Pam Taub and colleagues at UCSD in San Diego published a small randomized study showing that it improved heart rate control and improved symptoms and quality of life in patients with POTS. So it too is an option. Typically we start at a dose of 5 milligrams twice a day. That can be titrated up or down a bit as needed. Pyridostigmine or mestinon is a peripheral acetylcholinesterase inhibitor. It increases the neurotransmitter acetylcholine everywhere. So it can have broad effects. We showed in our inpatient setting that it did lower the heart rate in patients with POTS and improve symptoms. After that, actually, colleagues in Toledo, Blair Grubb's group, started using it a lot and then published a large clinical series of 300 patients and reported that while the vast majority of patients tolerated the drug, the majority felt better. But there's about 20% of patients that had to stop the drug, and almost always it was because of diarrhea and cramping. So I think it's a great option for patients prone to constipation, not so great an option for those prone to diarrhea. And I mentioned that lots of drugs we studied seemed to help, one didn't. So we looked at atomoxetine as an example of a norepinephrine transport inhibitor. So the norepinephrine transporter is also blocked by a lot of neuropsych drugs like Cymbalta, like Effexor, which is venlafaxine. Cymbalta is duloxetine. So in the SNRI drugs, that's where we typically see them nowadays. But atomoxetine is an ADHD drug that's on the market as well. And what we found is, unlike every other drug, atomoxetine raised the heart rate compared to placebo, both while standing and while seated, raised the orthostatic tachycardia, and worsened symptoms. Right? In fairness, not everyone's symptoms worsened. About a third of patients reports their symptoms didn't worsen, either no change or improved a little, but in 2/3 it worsened. So the take-home message is that POTS is really a chronic disorder associated with significant functional disability. There are treatments for the heart rate, but there are also treatments for the blood pressure. The midodrine really targets a blood pressure, blood squish approach. So you can tailor the treatments according to the individual needs, because POTS is ultimately a syndrome. It's not one thing. Dysautonomia is even more things. And so we have the tools, and then it's a matter of trying to use the tools in the optimal way for the individual patients. Ultimately, at this point, I have no cure for POTS. I don't make anyone have it totally go away, but it absolutely can be treated. And the vast majority of patients, we can make them better. The treatment paradigm consists largely of exercise, strategies to move blood back to the heart. And so that could be volume expansion, compression garments, basically getting more blood back to the heart. Strategies for heart rate control, the propranolol, the ivabradine, for example. And the final thing I'll say, and I haven't spent a lot of time on it so far, is that every one of these patients has a chronic illness, right? We're not making this go away. It's not a matter of take this treatment for a month and then never think about it again. And that's a change, right? Because a lot of patients were perfectly healthy until they weren't. And it's important that patients learn how to come to grips with that and manage that and learn to live with that and learn to control the illness and live with it as opposed to being controlled by the illness. And there are lots of strategies to do that, and there's not one right strategy for everyone. But certainly as providers, I think we need to make it clear this isn't a, do one or the other, right? Either manage the illness or try and treat the illness. It's a matter of really needing to do both. So with that, I thank you. Thank you for your time. Thank you for your attention. And again, I apologize for not being able to be live at this presentation.